So this sedation procedure went very well overall, completing SRP of 4 quads with local anesthesia and with moderate IV sedation. One of the challenges that we encounter with IV sedation is dosing in a way that is not overdoing it, but that is keeping the patient at a level where they're comfortable, where possibly they're a little bit amnestic after the procedure, even though we're not pushing big boluses to necessarily try to achieve that. We find that's a helpful side effect of IV sedation. And most of that comes from the benzodiazepines that we use, in this case, midazolam. We're also using a synthetic opioid, in this case, fentanyl, to achieve analgesia and to also add to the sedative hypnotic effect of the medications. Now, when we started the case, patient's blood pressure was good. It was around 130 over 80, and the heart rate was a little bit on the elevated side, around 85, nothing serious. After we started the sedation, however, after we did give that 2 milligram dose of midazolam, which was our first dose, we noticed that the heart rate did increase up to around 92, 93 beats per minute. And that persisted for about 10 to 20 minutes. And, it's not necessarily concerning, but it's something that I'm looking at. I'm kind of, whenever I see something that's the opposite of what I would have expected, which in this case, after midazolam, which usually has the effect of decreasing the heart rate. When we see something opposite of that, we kind of want to know why. And you don't always get an answer why. In this case, I didn't, although later on in the procedure, we did see the heart rate start to come down. So I followed that 2 milligram dose of midazolam with 50 micrograms of fentanyl given about 5 to 6 minutes afterwards. I don't like to give that second dose of any drug until I've seen what my initial dose does, and we kind of go from there. And we essentially gauge the patient's response and say, okay, is this patient hyper responding, hypo responding, or pretty much just going smoothly into the area we would expect them to. And we look at the eyes, we look at the droop of the eyelids, and kind of the eyelids will start to slow when they blink. The speech may become slurred, although honestly I don't see that very often. They usually just start talking less, or in some cases with other patients they start talking a lot more. And I wouldn't necessarily call that a sedation failure, because essentially what's happening is the patient is getting high. They're feeling good and they're relaxed and they're kind of opening up and chatting. And at some point they'll usually kind of start to chat less and may even start to drift off. But I want to make it really clear that my license only allows me to put patients in a place where they are comfortable, but sedated to a moderate level, which means that we can easily arouse them by saying, hey, Mr. Johnson, can you take a big breath for me? And they'll go, oh, they'll take that big breath in without even having to do any kind of tap on the shoulder or a sternal rub or anything crazy like that. You're just using verbal stimulation to kind of bring them back. Once we had given that synthetic opioid, in this case, the fentanyl, I do like to give a little bit of dexmedetomidine, which is becoming really popular these days due to its opioid potentiative effects, and it does have it's technically like a blood pressure medication. It's the same thing as clonidine. And what it's doing is it's acting on some different pathways in the brain, but also for a sedative effect, but it also does act on the heart to slow heart rate and then also to lower blood pressure through some other mechanisms. But really a helpful medication. I've heard anecdotally that it makes your sedation smoother when you use it. And I've noticed that. I feel like patients, when I use it, they come out of the sedation really comfortably. It's just smooth all the way through. They go into it comfortably. And I gave that about 4 minutes after the synthetic opioid that I had given, and I gave about 4 micrograms. And that's kind of like a standard starting spot for me. Sometimes I'll start with 8, not usually a lot more than that. As we went through the procedure, I like to be giving something roughly about every 20 or 30 minutes, because it seems like after about that 20 or 30 minute mark, we'll start to see the patient start to kind of float back up, and they'll start to twitch. You'll see their legs moving a little bit, or their hand might move, or they might start to reach up and start, rubbing, scratching their eye or something like that, which kind of tells me that they might be feeling a little bit uncomfortable or be starting to come out of the moderate level of sedation into more of like a minimal sedation, which there's nothing wrong with that, but I want to make sure our patients are comfortable and that they are essentially, for lack of a better term, kind of getting their money's worth from the sedation and feeling comfortable throughout it. It makes everybody's job easier. But by giving little doses as we go and metering the response and then kind of giving out more medication as we go based on what we see, how their response was, and what their response is to the stimulus as we go, it's really a lot more comfortable for everyone involved. It's more comfortable for me because I feel safe because we're just giving them a little bit as we go, because you never know what the patient may have on board. Could have taken something at home and they might have kind of pre-gamed for the appointment, and they could have a much more drastic response to 50 micrograms of fentanyl if they had taken 10 milligrams of oxycodone early that day at home in kind of preparation for this procedure that they expect is going to be really painful, right? So they might have a lot more on board than what we're thinking, because they may not have told us. A lot of times they won't. If they've taken 10 milligrams of oxycodone, a lot of times they'll know that's not something we would want. And we've told them not to do that. But when patients are scared, they'll do things like that. And so we have to be ready for it. And that's why it's better to ratchet the dosages back. And, like I said, in this case, I started with 2 and 50, but there would be nothing wrong with starting with 1 milligram of midazolam and 25 micrograms of synthetic opioid, of 25 micrograms of fentanyl. That would be just fine. And then kind of, you can always give more, but giving less is difficult, and then you're reversing the patient, which is really uncomfortable for everybody. And, kind of means that's usually the end of your procedure at that point. So, we had a good response as we were going through the sedation. There was one spot about an hour in where my hygienist, who was performing the SRP on the patient, while I was in the room, obviously, monitoring the patient and keeping, administering medications and monitoring vitals and et cetera. There was one point where she started to scale on the lower left-hand side, and the patient started to move and exclaimed, ow, that hurt. And so we knew, okay, obviously she's not completely numb on that lower left-hand area. Either the block is wearing off, or maybe I missed the block, didn't give enough. So I had started the block. I had only given one carpule of 2% lidocaine with 1 to 100,000 epinephrine standard. And I felt like I had gotten the block where I wanted it, but I went ahead and at this point, once she felt some pain in that area, I went ahead and gave another carpule of 4% septicaine with 1 to 100,000 epinephrine, just to be sure that she's completely numb in that area. And after we waited about 5 minutes or 10, give or take, and came back to that area to complete the scaling, she was perfectly good. So that's really important. Local anesthesia makes sedation go so much better, because if they aren't getting much stimulus from the mouth area, they're just going to be so comfortable that they can't even go to sleep during the procedure. So good local anesthesia, super important, even with sedation, obviously. Towards the end of the procedure, her heart rate did start to come down to kind of where I would have expected earlier on. It came down to around 75 beats per minute, and her blood pressure stayed pretty steady throughout the procedure, although I would say over the course of it, we did see her mean arterial pressure come down, as well as her systolic and diastolic. It started out at around 100 MAP, and by the end of the procedure, she was sitting at around 72 for the MAP, and that's a really comfortable spot for me. If she's going down to around a 60, I may start to become a little bit more concerned in terms of I wouldn't want to be giving much more benzodiazepine or opioid, or much less any more dexmedetomidine, which is also called Precedex. You may know it by that term. We want to kind of hold off on giving more meds, and I would probably go ahead and turn up the flow of her IV to try to sort of plump up her intravascular volume. Although I'll be honest, a lot of times I don't see a lot of result from that. So overall, sedation went really well. When we got done, we kept her in recovery for about 15 minutes with the nitrous and oxygen all off, just sitting there relaxing. And her vitals were super stable. She was awake and oriented, and she knew what day it was and didn't have any nausea. So her discharge recovery score was good. It's just amazing to me when you see these patients, they come out of sedation and they're in this like crispy, clean, like they're awake, they're relaxed, they're comfortable, they're not overly tired or sedated. It's really nice to see, because you feel super confident as you roll them out of the office in their wheelchair and deliver them to their caregiver. that they're going to go home and be okay. But I always give this post-op instruction. Maybe it's overcautious, but it makes me feel a lot better. I always look the caregiver in the eyes and I say, you need to understand that this patient has active metabolites in their bloodstream right now that once they hit their liver will metabolize into other active metabolites, which could cause oversedation, meaning it could cause their drive to breathe to diminish to the point where if they're laying back in bed and they have a tendency to obstruct anyways with maybe a large tongue or high BMI, whatever it may be, they could stop breathing and they could die. And I look the caregiver in the eyes and I tell them that, and then their eyes get really big and they're like, oh my goodness. And I'm saying, now what I would do to prevent that is I would keep an eye on them for the rest of the day. I have them sit up in an easy chair, kind of relaxed back, not laying flat in bed. Don't take them home and flop them in bed and forget about them and shut the door. I want you to keep them propped up in an easy chair or on the couch, whatever. Put them in front of the TV and kind of keep an eye on them until bedtime. And at bedtime, you can let them go ahead and lay flat and go to sleep. I feel a lot better about that because I've taken that monkey off of my back and I've put it right onto the caregiver's back, and it's not my problem anymore. I mean, it still is, but I've done what I can to adequately prepare them and to take care of their loved one like I would if it was mine, right? And so post-op instructions, really important. But yeah, throughout the procedure, I think the patient felt comfortable. She'll probably remember parts of it, maybe not all. So eventually I'll put together some cases where I have actual footage of a sedation from my office. When you're doing sedation, you can't really see what's happening inside the body. I guess the IV start is interesting, and then maybe drawing up the medications is interesting. But after that, it's really just it's all biochemistry and it's physiology and pharmacology is what is really happening. That that's the playground that you're in with IV sedation. There's not like watching. I would say IV sedation is more like a root canal than it is a wisdom tooth extraction. There's not a lot to see, but it's kind of the conceptual part of it is interesting. As general dentists in the United States, our hands are a little bit tied in terms of what we can do to, we can't really do a lot to prop up blood pressure. We can't do a ton to, ensure that our patients are like out. We're not trying to do that, right? We're keeping this at a moderate level, as I discussed earlier, and that's okay. That's good. It's just our toolkit is a smaller one, and that's for a reason. The Board of Dentistry got together at some point in the past and said, hey, these are the guardrails for general dentists. And honestly, the guardrails are nice because if a patient isn't comfortable with those parameters that I explained to them ahead of time, like, hey, this is the level of sedation that you'll be at, then they're not a good candidate for IV sedation in the office. And they need to go see the oral surgeon or the periodontist or, whoever else. Although periodontists usually, I think they're kind of at the level 3 moderate sedation. Someone could correct me on that. I'm not really sure. But, periodontists have very extensive training in a lot of things, so I'm not sure exactly what level they take. But in my experience of shadowing periodontists, I feel like the level of sedation they're taking patients to is around kind of a level 3 moderate parenteral sedation. Another thing I'd like to talk about sometime is the difference between IV sedation and oral sedation and what the difference is that you could expect to see. And I'll just, the short and sweet version is it's pretty much the same. Like, honestly, I've had patients go quite a bit deeper with oral sedation than with IV sedation, and it's sometimes a little bit concerning just because you can't do other than reversing them. You can't, you just got to wait for it to wear off. You kind of you have them take that pill, and then you're sort of riding the lightning until it wears off, and keeping them safe, obviously. And it's always very safe. I've never felt like it was an unsafe situation, but your control is just a little bit less, I would say. I would say IV sedation feels more like landing an airplane, and an oral sedation feels more like jumping out of an airplane and having a parachute, and just hoping that the parachute opens at the right time and does what it's supposed to do, and maybe that's a bad analogy, but it's kind of a fun way to think about it, maybe. Okay, so my drug totals for this IV sedation case that I was telling you about today were a total of 75 micrograms of fentanyl. Each little vial that you get is 100 micrograms, so it was almost a full vial. 4 milligrams of midazolam. I always draw up 5, and then usually I'll give 4 to 5 throughout the case, sometimes less. If it's a long case, I might give as much as 10, but I was taught to never go beyond 10 milligrams of midazolam just because the metabolites, that thing where I was mentioning that the liver metabolizes through a second pass effect, and then you get these other active metabolites, which is what makes midazolam a dirty drug. It makes it a little bit risky to start giving a lot of midazolam beyond like 10 milligrams. And that would only be in a longer case. Like, I'm not typically going to hit a patient with 10 milligrams of midazolam, like, just because they're not responding well. I'm more apt if someone's not responding well because, you never know. So could be genetic reasons, but a lot of times it's kind of past like drug users that don't do as well. Although I have a lot of patients who are recovering addicts that do really well with IV sedation or, oral sedation, benzodiazepines and fentanyl, even though they have a history with those drugs and their body a lot of times responds differently to them, that they seem to do really well. Okay, and then we have dexmedetomidine, and the total for that was 4 micrograms, of dexmedetomidine, which is not very much. When we're drawing up dexmedetomidine, we're drawing 40 micrograms because we have to do the dilution, and it's easy math. If you take 9.6 milliliters of sterile saline water and you mix it with 40 micrograms, you're mixing 0.4 cc's of dexmedetomidine with 9.6 cc's of saline, and that makes 10 cc's of volume, and each 1 cc you give of that is going to be 40 divided by 10 is 4. Each mil is 4 micrograms of dexmedetomidine, so it's easy math. I also did give ondansetron at the beginning. So the way the case went, I can kind of read it out here. It went from 247 to 427. So it was, just under 20 minutes under being 2 hours long. And that includes the recovery period. And we started the case with, first of all, I gave some ondansetron. That's probably not necessary, really, but this patient didn't have any history of an allergy, or we wouldn't be giving any of this stuff if she had an allergy, but any kind of like nausea response to opioids or any of the other medications. But it kind of seems like, to me, it's just like prophylactic. It's probably not going to hurt them to have it, and I would just hate for a patient to get nauseous while they're in the chair or when they get up from the chair, because after sedation is a big time for patients to get nauseous, and that's really common. A lot of times your patients will report that. They'll be like, yeah, I, had a knee surgery a year ago and I felt sick to my stomach afterwards. Like, that's pretty common. So, like, why not have a little bit of Zofran, ondansetron on board? Because we all know that, like, you can't give it once they're puking. It doesn't work. You can't give ondansetron at that point to stop emesis. Anyway, started out with 2 milligrams of midazolam IV. And then that was after the ondansetron, and then waited a few minutes and gave 50 micrograms of fentanyl IV. I gave the dexmedetomidine shortly after that, which was 4 micrograms IV. And then I waited about, the patient was having a response at that point, so I started anesthetizing just a couple minutes after that dexmedetomidine. She was looking comfortable, and so I said, okay, let's go ahead and start anesthetizing. And I pretty much like to stick with lidocaine when I'm doing IV sedation, because my feeling is they're sedated, and so their perception of pain is less. They're comfortable. They're not stressing. And so even though lidocaine does burn a little bit more than prilocaine, I don't usually use my prilocaine dosages, and that's for 2 reasons. One, I want to keep it really simple, and when my assistant is recording all of these different medications in XChart, which is a great software, by the way, if you're not using it, I would consider using it. I wanted to make it really easy that she knows to just like click the red stripe button. Don't worry about like all the local anesthetics that I would typically be using, just to keep it simple. Also, it's way easier to stay in a safe dosing limit and not overdose your patient on local anesthetics when you're just using lidocaine, because it's amazing how fast the carpule goes. It's like, oh, it's gone. And when you're using Septicaine or, something, Prilocaine, you just gave twice as much because it's a 4% concentration. And it's just easier to give too much, I feel like. So, and obviously we're keeping track of those dosages with XChart, making sure that we're not giving too much. I gave my local anesthetics. We did PSAs on the upper, and we did IN blocks and long buckles, and we did do palatal maxillary blocks, maxillary nerve blocks. Not the one where you go up, which is I always get it mixed up. Not the one where you go up the foramen of the palate. I've done that a few times, but not usually. Usually for all-on-4, stuff like that. We gave all of the local anesthetic, and then I did go ahead and give a little more midazolam because there was a couple points when I was giving the numbing where the patient was said, ow, so I'm like, okay, she's aware, she's not super deep, so I'm safe to give her a little bit more. I can just tell. So that was about 15 minutes after the first midazolam that I gave. So now we're at a total of 3 milligrams of midazolam. It was about, it was about 25 minutes later before I gave another 25 micrograms of fentanyl. And it was about 25 minutes after that before I gave another 1 milligram of midazolam. And then we were done. That was all I gave. And then the procedure lasted about another 25 minutes. And then we went into recovery period. Now, one thing I didn't mention is we used nitrous oxide through this whole procedure. And I really like the silhouette masks. I don't know. You guys can let me know what you think about them. But they're great, except for the fact that they're always kind of trying to flip up and go higher than they need to be. But they seem so much better to me than the big old-fashioned mask that sits, it's huge. It's like an elephant trunk coming off the patient's nose. And the silhouette masks are just so good. I usually put the patient on the nitrous oxide like right at the beginning, like before even starting the IV, because sometimes it helps relax them a little bit and make them a little more comfortable, although I feel like it doesn't really help that much. It could theoretically dilate the veins a bit as well and plump them up, but honestly, I think that's kind of like anecdotal. Probably not that much benefit there, but maybe it makes me feel better. I don't know. At least it's already on. I definitely feel like doing the nitrous oxide allows me to keep my IV sedation dosages lower throughout the course of the procedure, because it's just going to work synergistically with that nitrous oxide. And so that's another thing that I do. The little bit of oxygen flowing kind of helps prop up their O2 sats a little bit. It just seems helpful to me. Her O2 sat stayed super good through this whole procedure. She would have been just fine without the nitrous. But it's something I do right now. It's something I may change in the future. Patients seem to appreciate it. It just seems like it allows us to keep them more comfortable. So started the procedure, we started out typical stuff, PAM-NAP. P is for physical exam. A is for airway. M is for medications. N is for nothing by mouth, NPO status. A is allergies, making sure they don't have any allergies we didn't know about. Because obviously this should have all been done at like the pre-op appointment like a while ago. And then the last P, pre-op vitals, making sure that their pre-op vitals are looking good. And then we'll usually put on the nitrous, and then we'll start the IV with the 22 gauge needle. And I like to use 45 DW half normal saline. It's 0.45% sodium chloride with 5% dextrose in it. And that's just nice because it's kind of, giving them a little bit of sugar. So it's kind of supporting their blood sugar a little bit, which is good for, a diabetic patient, but also good for everybody else too. Because, when you're hypoglycemic because you haven't eaten for 8 hours, that's not really a great situation to be in. Thank you guys for tuning in for another episode of the Interdental Space. Really glad to have you here, and we'll see you next time.